Okay. We may just give it a minute or so to let a few more people join, but then we will get started with our webinar for tonight. So thank you so much to everybody who's already joined. And we will get going here in about 30 seconds or so. We'll just give a few more people time to get on. All right. Well, I think we will get going. Welcome to everyone who's joining us. We're so thankful to have you. For those of you who don't know me, my name is Dr. Christina Francis, and I'm the CEO of APLOG, the American Association of Pro-Life OBGYNs, who is hosting this webinar tonight. So we're so thankful to have you with us. I'm really excited to be here and to talk about such an important issue, which is how do we compassionately care for patients who are dealing with pregnancy loss, specifically in the context of an emergency department? As a board certified OBGYN and also somebody who works as an OB hospitalist, I have the privilege and honor of being with women through some of the happiest times of their lives, but also some of the most difficult times of their lives, and I think some of the most difficult times in their families' lives as well. But I've often said that in some ways it's a huge honor actually to be able to be there with patients during those times. Of course, those of us who deliver babies find so much joy in that, but I think probably anyone who's watching and listening who takes care of women and families during the difficult time of pregnancy loss will understand what I say when I say that it's an honor to be there during that very difficult time, and to hopefully be able to make that time a little less painful and a little less difficult for them. But I'm sure, like me, you all have seen this handled well and handled maybe not quite as well in the emergency department, which is often very, very busy. And, I think for patients going through these very difficult times, oftentimes the quality of care that they get from the medical staff that they encounter in the emergency department, and I know our guest is going to talk about this tonight, but from even the person who's checking them in at the emergency department all the way through to the person who is handing them their discharge papers, they may remember that interaction. In fact, they likely will for the rest of their lives. For better or for worse, I think at times. And it certainly has the ability to profoundly impact not just their physical health and how they're cared for physically in the emergency department, but also their mental health as they deal with the trauma of their pregnancy loss. But what our hope is, and what we're going to talk about tonight, is that we're not adding trauma to that trauma that they're already going through by not giving them compassionate care. So it certainly is of the utmost importance that we are equipped with knowledge and resources to be able to give patients the best care possible. And of course, for those of us who are OBGYNs, oftentimes by the time we might be getting called down to the emergency department, they've already received maybe hours of care in the emergency room. And so I think this topic that we're going to talk about tonight of helping train emergency department personnel and how to also give compassionate care to women in these situations is so crucial. And so I'm honored to have our guest with me tonight to talk about that, because she really is she and the institute that she leads are doing really groundbreaking work in helping emergency departments understand how to better care for women, and also producing data to show the difference that can make when emergency departments are trained in that. But before I introduce our esteemed guest for this evening, you all can already see her, but I wanted to just quickly encourage you to engage with us with your thoughts and questions. You can drop those in the chat during this webinar, and our moderator Miriam will be collecting the questions that you drop in the chat throughout, so feel free to drop them in there as soon as you think of them. And she's going to save that for the Q&A portion of the webinar, which will be after the presentation, so around 8:45 or so Eastern time. We will try to get to all of your questions during this session if we can, but if we can't, Don't worry, we will be sure to answer them in the near future in a follow-up email. And we even take some of the questions that we have at the end of our webinars and incorporate those into podcast episodes sometimes. So feel free to drop many, many questions in that chat, and we'll get to as many of them as we possibly can. All right, so with no further ado, it is my honor to be here today with Michaelene Fredenburg, LHD. She's president and CEO of the Institute of Reproductive Grief Care. Dr. Fredenburg is one of the world's foremost experts on pregnancy loss and reproductive grief care. She serves on the editorial board of Newborn, the official journal of the Global Newborn Society, which publishes research related to neonatology. She also founded the Institute for Reproductive Grief Care in 2008, establishing it firmly at the forefront of creating impartial and impactful research to understand the way individuals process reproductive losses, as well as to establish global standards for offering compassionate care, which is so, so important. She is the author of Changed, Making Sense of Your Own or a Loved One's Abortion Experience, as well as Hope After Loss, and Grief and Abortion, Creating a Safe Place to Heal. She received her Doctor of Humane Letters from Divine Mercy University. Dr. Fredenburg is here to offer some answers as to how emergency departments in particular can best care for patients facing pregnancy loss. Michaelene, it's such a pleasure to have you with us. I'm going to let you take it away now and share your expertise on this issue with us.
Great. Thank you, Dr. Francis. It is really an honor to be here today and to be with all of those who are joining. So I'm really excited for this opportunity to share some compassionate care tips and then to answer any questions that you may have. So I think, well, first of all, I have nothing to disclose. We always want to say that. And I do want to talk about just what is it that I'm hoping that we'll accomplish in our time together. And so at the end of this time, I'd like it that we could describe the impact of this practice gap of reproductive grief care in the emergency department on both providers and patients. Also, distinguish communication approaches that facilitate emotional healing rather than those that intensify anguish. And then incorporate at least 3 practical applications that promote emotional healing after reproductive loss. So I always like to start at the beginning, even though these are statistics and information that you may be aware of. And actually, before I even go into the statistics, I want to read to you an all too common scenario. And that is, imagine, if you will, there's a couple rushing to the hospital in the midst of a miscarriage. They're scared, they're confused. Amid the chaos of the emergency department, they're told, at least it was early, and sent home to complete the miscarriage alone. She's discharged with little guidance and no dignified way to collect their baby's remains. Her partner is overlooked and their grief is ignored. As I said, this is a scenario that's repeated probably hundreds of thousands of times every year. We know from research that about 900,000 emergency department visits will happen annually for early pregnancy loss concerns, primarily for miscarriage. But there's about, FDA says about 1 in 25 who are undergoing a medication abortion will also spend some time in the emergency department. And because of the lack of protocols and training, there are really devastating consequences. 60% of those couples are going to experience difficulty adapting 2 years post-loss. That means they're going to be experiencing symptoms of anxiety, depression, PTSD. Up to 75% will experience a complicated or prolonged grief reaction. That's in comparison with 5 to 7% for other types of losses. And the negative impact is not just on the couple alone, but certainly on providers too. We know from research that the lack of training contributes to compassion fatigue and vicarious trauma for nurses. And I'm going to imagine that that could be for others as well. So we all want to be providing the best possible care, but we know that there's a lot of barriers, in particular in an emergency department. And there are some that are listed here that we've heard: lack of resources, lack of knowledge. Maybe you have a personal grief history yourself, and that makes it more difficult to interact with patients who are undergoing a loss. There's a lot of fear, like, am I going to make it worse? And then maybe just really feeling uncomfortable with those conversations, as well as lack of time. And maybe you can think of other barriers as well, and you can certainly feel free to put those in the chat. Fortunately, I said the good news is that through training and through our help with protocols, we can overcome most of those barriers. The one we cannot overcome, though, is the lack of time. Fortunately, though, it's not always the amount of time that you're spending with a patient. It's how you're using your time and how your team is using that time. And so we'll talk about that as we go throughout the rest of our time together. But before we do that, I'd like to set a little bit more of a stage of what research tells us about the unique aspects of reproductive loss and what contributes to this really intense experience that many people will have. So there is a whole body of research using the perinatal grief scale that spans about 40 years at this point of time. These studies have been completed worldwide, and they're conducted on both partners. There's 33 questions. They're broken up into these subsets that you can see here: difficulty coping, active grief, despair, with despair being the one that we see correlating the most seriously to adverse outcomes. So grief scores tend to be actually pretty similar for both members of that couple. With the person who's been actively losing the pregnancy, scores are typically a little bit higher, but that begins to change at about 2 years. That's a whole different topic that we could get into, other than just saying how important it is that we are providing care for the entire couple that's there. But one thing that we also see with the perinatal grief scale studies is that there is no correlation between the duration of the pregnancy or the length of the pregnancy and the intensity and duration of the grief reaction. So Lang and her, she has a number of colleagues that do another body of research when it comes to perinatal loss. And there's just this little quote that I think really encapsulates. She says, perinatal loss has well-documented detrimental effects on the health and well-being of the bereaved parents individually and as a couple, compared to other types of mourning, like the loss of a parent or a sibling. The loss of a child is associated with a grief experience that is particularly severe, long-lasting, and complicated. So this is not to minimize or diminish other types of losses. It's just to point out that there are some unique aspects, or what Dr. Warden would call mediators, to grief when it comes to a perinatal or reproductive loss. And I want to cover just a couple of them again to give a little bit more information about why this is happening, but also each of these you can actually speak into, and you can in a helpful way. And so one of those aspects is the disenfranchised nature of a reproductive loss. And what do we mean by that? Dr. Doka coined this phrase. So this is a grief that's not culturally acknowledged. It's a loss that's treated as a non-event. And so individuals really get the message that they are not entitled to grieve. Addition to that, Dr. Jaffe and Diamond's work showed that, well, certainly everybody's experience is very unique. So I'm also not trying to suggest that everybody is going to have as intense a reaction as others. And there are a number of different factors for that. But they did see some other similarities in the treatment of their clients and in the studies that they did. And it really touched on, there's multiple losses that occur with a reproductive loss. And so they heard over and over again this sense of, in addition to their child dying, They felt that a part of themselves had died in the process. Also, because of the hopes and the dreams that we attach to our future children, that actually begins at our reproductive story from young on, there's this loss of hopes and dreams. And then there's this profound sense of failure. I think in our culture, we kind of have this kind of children on demand type of a thing. So we think that we can, get pregnant and produce a healthy child when that time is right for us. But as we know, that doesn't always happen. But with a cultural silence, there's this feeling of failure. This is even replicated. There was an NPR study that showed 50% of the respondents said they felt guilty, 25% they felt shame. And then there's this ambiguous nature to a reproductive loss. And so, what do I mean by that? When we have lost somebody who has lived longer in the world, today's the anniversary of my father's death 13 years ago. And so I miss my father terribly. But one thing I had is my sister texted me first thing in the morning, and I'll be seeing her next week, and we'll be sharing memories about my dad. We have pictures, we have tokens. He has these different collections. He has this beer stein collection, and we all got a beer stein, and that sits, in a place of honor. And so we have these things that connect us with those who have departed, and it allows us in that grieving process to grieve not only individually, but to grieve communally. But when it comes to a reproductive loss, we often don't have those types of token, right? We don't have that tangible interaction. We don't have physical things to remind us. Also, culturally, we're often not offered any sort of ritual or service to be able to memorialize and to remember. And so this all feeds into one of the greatest fears that families express, and that is that their children will be forgotten. So let's look a little bit into the tasks of grieving. I think this is going to start to put it all together for you. So Dr. Warden, I already mentioned him. He's one of the foremost experts on grief. And so he talks about grief as work. And I think any of us who have grieved, it's hard work. It's exhausting. Even though we have different styles and different ways that we grieve, we often find ourselves really exhausted throughout that grieving process. And so he said there's different tasks that we work on. And these tasks don't happen in any particular order. You're often working on multiple tasks at the same time. But let's go over them quickly. So there's accepting the reality of the loss. Right, that's hard for us to do. There's this sense of I can't believe that. Or for months I would think about, oh, I'd love to share this with Dad. And then oh no, I can't. It's difficult to do that. And there's also the processing the pain of the grief. Both of these tasks, the disenfranchised nature of a reproductive loss already make that more complicated and more difficult to do. So if those around us don't acknowledge, if we don't have people to talk through, if we haven't been given permission to grieve, you can see how it would be really difficult to actually work on these particular tasks of grieving. Then he also talks about the task of adjusting to the world without that person, right? So even though we haven't met the person in this instance with an early pregnancy loss, we began to envision a life with them. So we have to adjust to that. It's a different future, it's a different reality. And in the midst of that, it's finding an enduring connection so that we have this desire to carry that person forward with us. So then again, going back to that ambiguous nature of the loss, you can imagine how that makes it much more difficult. In fact, for many couples, they find that their grief or their guilt or their shame is the most tangible connection that they have with their child. And they will sometimes hang on to that very tenaciously because there's this fear of if we let that go, again, that our child will be forgotten. So let's now talk about what we can do. And I'm going to look first. I kind of broke this up into to more of the role of the provider because you have such a unique role. And already, as Dr. Francis said, what you say and do is likely to be remembered for the rest of their lives. And so I know it's a little scary because in some ways you have a lot of influence over setting that grieving trajectory. Um, but there's also really simple but profound things that you can do that can set a much more healthy grieving trajectory and set them forward into a different grieving journey for them. And so let's look at some of these acknowledging the loss, right? We've already talked about that. You can see why that would be so important to say that you're so sorry. And then, of course, mirror the language that the patient is using. If they're saying pregnancy, baby, fetus, we would want to say, we're so sorry for that loss. And then listening with compassion and empathy is actually starting to help the processing, the pain of that loss. So back to that task of grieving. And in doing that, you are giving your patients permission to grieve. A really key concept, right? A miscarriage often is not a physical emergency, but it is most definitely an emotional emergency. And so to speak into that, we really want to come with this empathetic, compassionate approach, whole person care, right? Patient led. And we really do that through companioning with the patient. And I would imagine that you already do this really well. So hopefully, this will build more confidence that the things that you're doing are really helpful for the patient and their partner. And so it's right, companioning is really kind of boiling it down. It's almost thinking of a power differential that in a treatment, a traditional treatment approach, it's more like the provider's an expert because you are, and in a way, kind of focusing on fixing, making it better. Um, a companioning approach is a much more collaborative, and the focus is on building trust. And in this instance, the thing is that you can't stop the miscarriage that's underway. What you can do is you can provide them with that acknowledgement and companion with them and be present in that moment. And so that power differential changes, if you will, from expert into a friend or into a companion for them. And you can literally do that through how you position yourselves. So, starting with rather than standing, sitting, doing something that gets you more eye level and maybe a little closer to the patient and their partner, making sure that there's eye contact. I know this can be difficult when someone is experiencing great pain, or there's a lot of shock, or you're literally you know that you only have a few moments to be there, but that eye contact will make a huge difference. Obviously, your tone of voice and your body language in general. If you're able to say that it's not your fault, that message is going to be really impactful coming from you. And that's really going to help with that. That guilt is going to come forward, but you starting those messages early for them that it is not their fault. Time, of course, is going to be an issue, and you may be rushed, but your patient doesn't have to know that you're rushed. If you take a moment to sit, to listen, to deliver bad news, and we're going to talk about some of those compassionate communication skills, and for those few moments for them to feel like they're the only ones, that they have your full attention. And of course, you're not going to be able to spend a lot of time. You can even verbalize that. You can say something like, I wish that I had more time to spend, but you're going to get the best care from our team. That is very comforting. And that also really helps to set up the team approach, which we're going to talk about shortly. So those compassionate communication, that'd be good to share some of the latest research when it comes to this, Dr. Brand and Dr. Butte have now created, um, they have a whole series now of research that's they have completed on this. They're at Indiana University, Indiana, formerly IUPUI. And so I thought I'd share with you some of the things that they have found, that have been expressed by patients, that these are their preferences. And so we're going to look in these three groupings here: demonstrating empathy, which I know that's exactly what you want to be doing. And so some of the ways that you can do that is by responding to the cues. So responding, taking again the lead from the patient, responding to that in how they respond, how they articulate the loss and the emotions that they're having. So you're responding to their cues, again giving them your full attention, and just your empathy itself is providing comfort to them. Then allowing some space to process, right? This is a lot. It feels, it can be shocking. This is for many completely unexpected, and it seems to be happening fast, and they're feeling out of control. And so if you could allow some space to process that, even in the limited time that you have, silence is a big part of that. So being comfortable with silence, and I think it's hard to be comfortable with silence, but allowing that, that's allowing them to process that to as much as you can to avoid rushing. And again, going back to that companioning approach that we were talking about. Also, using that teach back method, which can be again about kind of the responding to cues, and helping them to create space to process. So you can say things so like, what I'm hearing you say is, right? Those type of ways of repeating back. They will affirm that, or maybe they'll correct you. Maybe they actually are meaning something really different, but you're allowing them then to teach you and to lead you in that. Patients also had some really strong opinions about words that they would like to be avoided and that they found to be traumatic. And so at the top of their list was avoiding the term abortion. Now I know the medical term would be spontaneous abortion, but all they could hear is abortion. This sent them into, they felt guilty. They felt like somehow that meant they did something to cause this. Others, because of their belief system, this was something that, it was just terrible to hear those words. It was terrible to hear them. It was terrible to see them. And so certainly, again, trying to reflect their language, but certainly avoiding the word abortion either to them or overhearing. So often they overhear a lot of what teams say to each other when we're not really thinking about that. They also really requested that, well, yes, they know that they need to learn what happens next, but they found overly detailed descriptions to be very traumatizing and create images and things that would become flashbacks for them in time. And so being careful about being accurate of descriptions, but also being as gentle as possible. There was very specific requests not to use parts, not to use things like scraping the uterus. And there's more on the research on this, but this really gives you some of the highlights and some of the things to think about in your communication with that patient. This may not be something that you're doing as a provider, but certainly somebody on the team, whether it's maybe the social worker or the chaplain, or it may be the nurse as well. And maybe this question would be asked a couple different times. but inquiring and not making any assumptions about cultural or spiritual care. But again, when it comes to an emotional emergency, this is something we need to think of, right? Whole person care. And so their cultural and spiritual preferences are going to be really important. And simply asking those questions. Something as simple as is there anything about your cultural or spiritual practices that we should know that would help us in providing you with the best care? And then that's something that can be explored, typically not with you. That's going to be probably your chaplain, but it might be the social worker. And again, don't assume, always ask, and then assist them with what they're expressing to you. And so that I think is the perfect transition to actually talking about the whole team. And so our team at the Institute likes to say that whole person care requires an entire team. As Dr. Francis said, from registration through discharge and beyond discharge. And so let's look at a few of those things. We'll go over these really briefly so that we have time for questions. So we have, of course, everybody's going to be acknowledging the loss as it's appropriate, listening with compassion and empathy. All of that's giving permission to grieve. And then there's some other really important things to do. And that is certainly making sure, and I don't have it here, but I want to touch on that. But this is making sure that there is a dignified way to retrieve the remains of their child. So if they're going to be completing the miscarriage at home, making sure that they are sent home or at least offered a collection kit and described. That's going to be a difficult conversation, but it's an important one to have, and it is much better than letting them go home, be unprepared, and then miscarrying in the toilet, in the bathtub, and you can imagine what that creates later on, and often creates things that forever will haunt them. I flushed the toilet, or I don't know what happened to my baby. Maybe the miscarriage was completed within the hospital setting, or there needed to be a surgical intervention. So really talking that through, a nurse and a social worker will definitely be really helpful in this situation. Then also offering options of memorialization. So certainly the nursing staff can be involved with this, but the chaplain's going to have a really important role in doing that. And so part of that is, right, memorialize for the remains. I know sometimes that there's not like enough remains, even if we're thinking of cremation, but you can get creative. I know some of our teams talk about, putting a baby blanket or some other items so that there's enough so that there can be burial. And then, of course, there would be the chaplain most likely would be talking with is this will be transferred to a funeral home, or is this something, does the state allow them to take home and they can bury in a way that they prefer to do that? But so there has to be some knowledge in the area of what your hospital policies are, as well as what the state laws are in this place. There's other things that can be done as well. Offering, if there were any sonogram pictures that had been taken, would they like a copy of them? Perhaps the staff is going to sign a sympathy card. That may be the only sympathy card they're ever going to receive, and that will become very precious to them. Additionally, we can think of other items depending on how far along in the pregnancy. There may be options to take photos. And so all of that can be explored and offered with the patient. I know there's some hospital auxiliaries that will do things like, a blanket or booties or a cap, gathering all those things together and making sure that the couple has that to take home with them. Those are just some ideas. Also doing a letter that would be acknowledging their loss. So there's not going to be a birth or a death certificate, but you can actually have an acknowledgement. And this, we actually at the Institute, we have some very simple templates for that. Again, these become precious items for the couple to take home with them. Again, depending on how far along they are in the pregnancy, lactation may need to be discussed. You can imagine how traumatizing that can be to go home and then in a couple days later they're beginning to lactate. No one even told them there was a possibility. They have no idea what to do. So preparing them with that knowledge and then giving them options, including if there's a milk bank that your hospital is associated with. There's lots of different options that are there as well if they choose to do that. Making sure that there's really clear and easy to understand discharge paperwork, again, that is gentle language and avoids words like a spontaneous abortion, and that they're provided with some resources that they can access later if they would like to do that. Also, being that bridge to their care post loss. Both canceling any prenatal appointments so they're not getting a text reminding them about their next sonogram, but also making sure that they have a postpartum appointment scheduled. And this is another area of like right now, typically after a loss, especially an early loss, the patient is not treated as if they are postpartum, but they are. And they really need that specialized care. And so they can be a bridge to that with helping with those appointments. So we teach in our program a concept called a chain and compassionate response, really similar to what you learn if you've been through any recent CPR training, right? But again, we're talking about how as a team do we work together on this, including warm handoffs that will be occurring from person to person to person. So if I could, I'm going to go back to that earlier scenario that I laid out, and I'm going to share a different scenario that actually happens with one of the partners that we work with, one of the emergency departments that went through our entire program. And let's imagine this same couple, and they're going to this emergency department. And so they are going to be receiving compassionate support and acknowledgement from the moment they show up to check in and to start that process of right giving insurance and information there. So they're taught with that. If there was transport, EMTs are also trained on how to begin this compassionate support to those individuals and that empathetic language, compassionate care. Also, what happens is that as they're checking in, that receptionist is texting the social worker and the chaplain to let them know. And so often that couple then will not have to wait alone to be seen. They'll have a chaplain or a social worker that's sitting with them and not only there to sit with them, to help to assuage their fears, but also they're listening and they're learning how to best care for that patient. Knowledge that they begin to then tell the next person, the tech or the nurse who's going to be seeing them next. And then this information is passed on from one care team member to the next, ensuring also that the cultural and spiritual preferences are observed, and then shielding that couple from unnecessarily repeating their story over and over and over again. Confirmation of the loss is delivered with empathy. Discharge instructions are communicated clearly along with support resources. If it's appropriate, they will be offered a miscarriage collection kit, as well as there will be memorial options, including burial, that are included in the packet that they receive with their discharge packet and their support resources. So the couple leaves knowing that the remains of their child will be treated with dignity and respect, and they will have the comfort of knowing that there are other witnesses to their child and that their child will not be forgotten. I'm thrilled to actually report within this is Scripps Health that I'm describing the experience that we now have. And in the research, In fact, I can show the evidence-based interventions, just to give you a synopsis, are we do a limited gap analysis with their team so we can learn best what they have available and where the gaps are. It also helps our team to personalize a bit of our program for them. We then have their lead. It's different in each way, but in this instance, it was the head of the emergency department went through it. In other instances, it was a nurse. Other instances, we've had integrative behavioral health or the perinatal bereavement coordinator be the project lead. And so we go through the best practice coaching. So they learn those best practices and the evidence behind it, and then looking through a rubric, right? How are they doing and where are the areas that they can improve? They also then choose multidisciplinary teams that are going to become the mentors for others, and they go through a little bit more intensive training. So they'll have about 7.5 hours of training. 5 of it is on demand and online, and the other 2.5 is either in person or a live virtual interactive webinar where we do the case studies, role plays, we go through these scenarios. And then everyone on their team in the emergency department then has access to the recorded courses that they can take on demand. Scripps did not do this because there's only 2 hospitals. But for another partner that we have, Common Spirit Mountain Region, they they have 20 hospitals. And so in this instance, we also certified instructors so that they have that sustainability and of the project, and they can roll it out and continue to have that multidisciplinary intensive can be taught to new people as they're onboarding in that process. We just completed research with Scripps. We're in the process of research with some of our other partners, but at Scripps, it showed that there was significant improvement across all of the educational intervention domains. And also, we did not expect to pick this up on it, but we were so delighted that it did. It clearly showed increased team cohesion and morale. Really wrapping up, it's just, and I can see there's some questions that are coming in, but I really do encourage you, please use us as a resource. The work that you do is amazing. The impact that you have on patients, their partner, and their families is huge. And we know that you're endeavoring to do your best. You don't always have a lot of support. Trying to do this on your own is really hard. And so if we can help to bring a whole team on board so that you have that support and could be providing that type of compassionate care, we want to be able to help you with that.
All right, thank you so much, Michaelene. And I think we can now switch. Miriam, if you want to stop sharing, and then maybe we'll just both of us be up on the screen so that we can take, because we've been getting some good questions in. And thank you so much, Dr. Fredenburg. Every time I listen to you talk, I learn something new, and that includes tonight. So thank you so much. I know that this will be a huge help, just even what you shared, but also hoping that we have people that are listening and watching that are interested in bringing you all's training program to their hospital system. So hopefully that will, and we'll round back with how to reach you again before we say goodbye to everybody. So I'm going to start with some questions that we got in the chat. The first one is, what cultural or religious beliefs have you encountered in your interactions, or maybe interactions with emergency departments, that have maybe surprised you or impacted the kind of care that patients have received?
Oh my gosh, that is a really great question. And of course, we're doing the training, right? So we're training the individuals who are now carrying this out. So I don't always have some of that firsthand. What I can say, and I'm sure, I mean, right, across the country, we have really culturally diverse, and it certainly here is in San Diego. So for instance, we also work with community health centers, and one of them that we work with, they speak 50 languages. Their patients speak 50 languages. So you can just imagine. So I have to say that what we continue to hear from those who are working with is that they just really love it, that they don't have to be an expert
Mm-hmm.
in all of these different religious preferences or cultural preferences, that rather than, I think at one time, right, it was cultural competency, where we really encourage cultural humility. That there is absolutely no way that we can know. And so asking the questions mean that it is always led. It is led by those individuals that are there. But it's so important to ask those questions because, as you can imagine, there have been, oh my goodness, I can think of one that like was handled really poorly.
Mm-hmm.
Um, I don't know. There was just an assumption made, and they pulled a chaplain in who began baptizing a Jewish couple's baby,
Oh,
right?
sure.
So
Yeah.
this was just, oh my goodness, right? And it created chaos and confusion, and then trust was broken, and
Mm-hmm.
it was just awful. Um, but then, even within religious, I know speaking with an imam who was helping our team, he was describing, right, that even within, um, there are very different practices depending
Sure.
on like different sects or
Mm-hmm.
beliefs when it comes to early pregnancy loss. So, again, asking questions and then trying to make sure that we can connect, that chaplain can help to connect with their spiritual leader, so
Mm-hmm.
we're making sure that they're getting the best care. So I don't know if that was
Yeah.
helpful.
Yeah, no, absolutely. And I love your use of the phrase cultural humility. Understanding that we're going into it not understanding, but we
Yes.
can we can gain some insight just by asking very simple questions, as you
Yes.
said, of the patient and their family. Are there any
Yes.
specific religious practices that you would like
Yes.
to happen that we need to be aware of? Things like that, and that patients and the feedback that you get from people that you've done training for, does it seem like patients are receptive when they use that kind of
Yes.
open and humble approach?
Yeah, they are very receptive to that. And that also does, rather than the like, sometimes we feel, because you all are experts, we're encountering you in this moment, that sometimes we don't feel like we have a lot to add. So this is also
Mm-hmm.
giving a lot of permission so that it's going to be patient-led care. And we also know that with a loss like this, I'd mentioned earlier, you feel out of control. So
Yeah.
the more that we can do to start to give back agency and control, we can do that through simple things like asking which arm they prefer an IV to be put in. Can I get you a warm blanket? All of that, giving the option to say yes or no, is
Mm-hmm.
actually really helpful. But then certainly now we're going into deeper areas as well, that we're able to enter into this with them, and it creates this incredible alliance
Mm-hmm.
with the patients.
Wonderful. Amazing. All right, moving on to our next question. Um, Someone was asking, do you have a list of options to memorialize first trimester losses? Or maybe in addition to that, you can, because I know you talked about miscarriage
Mm-hmm.
collection kits, which are not
Right.
always widely available. And so, can
Mm-hmm.
you maybe list out some resources for that, or
Yes.
things that you've
Right.
seen hospital systems do?
Yes, and I'm also thinking too, that maybe I can provide you with a few of the templates that we have, so
Wonderful.
people you can look at that as well, like the gestational letter that I mentioned too. So yes, and people can get really creative. So certainly, I already mentioned tapping into the hospital auxiliary can be really really helpful. When I mentioned the miscarriage collection kit, some of the hospital auxiliaries will provide some sort of discreet and beautiful covering that can be put over a specimen cup, because
Mhm.
that's going to be part of it.
Yeah.
And so that could be knitted, or some have used wedding garments that
Mhm.
they have now repurposed. So it's satin and lace. It's beautiful for them. Definitely sympathy cards are utilized. Getting creative around potential photography.
Mhm.
Um, Again, the ultrasound photos that are there. Um, Sometimes it can be, we have forget me not pins. You don't have to use a forget me not pin, but sometimes hospitals will actually come up with their own pin or token that they then pass on. It could be a stone, it can be a candle. All of those are very meaningful for individuals and will really be cherished. Now, it can be a little overwhelming as well. So
Sure.
sometimes putting those into a beautiful bag or a box, allowing them to take it, and even offering things again we don't want to force. Maybe they don't want to. Maybe it's just too much because it makes it seem too real, too
Hmm.
final. So you can offer that they can come back and get it, or suggest maybe take it home, stick it somewhere in the garage or the closet, and then decide later whether you want to keep those items.
Yeah, that's such good advice. I know at my hospital, they actually do a really great job. Of course, it's a bit easier to get some tokens of remembrance sometimes if the baby's a little bit, if the pregnancy's a little bit
Right.
farther along, but even, taking photos, and then if the family is unsure if they want them, the hospital will hold on to them for a
Yes.
while and tell the family, you know what,
Yes.
if you change your mind, we're going to keep these for you, and you
Mm-hmm.
can always come back to get them. And
Yes.
our hospital also has an angel gowns program that takes
Okay.
wedding dresses and
Mm.
changes those into beautiful
Right.
gowns for babies
Right.
who have passed. And so
Right.
I know there's any number of things that can be
There
done.
is.
There's really amazing work that's being done in this area actually with saline baths for
Mm.
babies who maybe have
Mm-hmm.
passed away, a
Yes.
while ago before they were delivered, to try and restore a little bit of integrity to
Mm-hmm.
their skin and things like that for
Yes.
parents to have that remembrance. So,
Yes.
I think if we just go as medical professionals and
Yes.
emergency room personnel, if we go into this with the thought of what is something or a few things that we
Yes.
could do that will help this family be able to remember their
Right.
child,
Yes. Yes.
that's good. I even
Yes.
taking care of a patient in the emergency room once who was actively miscarrying, rather than the nurse, having the specimen cup right away and things like that. We just even took a
Yeah.
simple little 4x4, and I had already asked the patient if she wanted to see her baby, and she did. And so we just kind of wrapped the baby up in a
Mm-hmm.
little 4x4, just so
Yes.
that she had a way of holding
Yes.
her baby for a little while. So
Yes.
I think that there's any number of things that can be
Yes.
done. So
Absolutely. I was thinking when you talk about the photography too, I know one of our partners we work with, they're up in a little north of Seattle. But so when you talked about photography, so they found with doing water photography that
mhm,
you often have better results. And so I think there's also very innovative things that are
yeah,
happening. And then some have taken it a step further, and maybe your hospital system does this as well. I know at Scripps, they now are offering a memorial service twice a year.
mhm,
And so sometimes it's just too much at that time, but now it's offering a way to come back. So they do one in the spring and one during October during Pregnancy and Infant Loss Awareness Month. And
mhm.
that's been responded to in a very positive way.
Yeah, absolutely. Yeah, my hospital has that as well, and I'm sure many other people's do. And I think that's a nice way for if the family is very unsure about,
Yes,
we don't want to make that decision, they can
yes,
still know that their
yes,
child is being treated with dignity and
yes.
having a proper burial. And so I think
Mm-hmm.
that is really helpful in the grief process,
Mm-hmm.
as well. Um, a question that I had, and I don't know if we're getting any more in the chat, but a question that I had, would be, what are some very practical things? I know you and I talked about this a little while ago, but maybe some just very practical things that busy physicians, oftentimes as physicians, we don't have as much time as we would like to have to spend with our patients. The nurses certainly spend a lot more time with the patients, but as busy physicians, what are some really simple things that we can do in these kind of situations to convey the compassion that we do truly feel
Mm-hmm.
for our patients in this scenario? One thing, when you and I were talking, I said I always try to sit down when I'm
Yes,
talking to the patient, as opposed, like, even if I can only stay in the room for 2 or 3 minutes because it's,
yes.
things are really busy, whatever.
Right,
I always try and sit down so that I'm not hovering over the patient, so that they understand I'm trying to, I'm
mm-hmm.
on their level, trying to show that compassion. So that's
Right,
one thing that I try to be really cognizant to do. What are
yes,
some other things that maybe you've had people tell you, or that you all talk to people when
right,
you're doing the training? Just simple things that we can do in a short period of time.
right. I, I think again, even though you don't have a lot of time, we don't have to fill that time with words.
Mm-hmm.
And so certainly say acknowledging, right, acknowledging the loss. And if you're not sure how, how to, you can now say, I'm so sorry you're going through this. We're
Mm-hmm.
here for you. I think again, those message, if you can, that it's not their fault. They're going to need to hear that over and over again. I know one of the physicians we work with says that she actually will say, she'll say, it's not your fault. And they might even nod, and she'll say, it's really common that you're at some point that voice is going to start in your head. And it's going, that voice, it was, if I did this, if I did that. And I
Mm-hmm.
just want to tell you that's normal, but it's not your fault. I want you to know it's not your fault. So, really emphasizing that, because people really get stuck in that place. And you can do simple things too if they're crying or numb or angry. I think a statement of like, it's normal too,
Yeah.
fill
Yeah.
in the blank. Because now again they're feeling this or they're crying. We often apologize, right? Oh no,
Mm-hmm.
it's normal to cry, or it's
Yeah.
normal to have no tears at all. um, if they're saying maybe they're relieved because they weren't necessarily sure what they thought about the pregnancy, but then they're also sad.
Mm-hmm.
Like say it's really normal to have really mixed emotions.
Yeah.
So any of those types of messages that we can give, this is not your job. I'm saying as a provider, but it may come up because if the couple's responding very differently from the
Mm-hmm.
outset, to make a comment about just saying like everyone agree. I just want you to know that everybody reacts differently. Everybody agrees differently, and that's really normal.
Mm-hmm.
And we can support each other in that. And hopefully the social worker is going to repeat that again, and then hopefully the chaplain's going to repeat that
Yeah.
again to them as well. But it's I like it, the eye contacts, your eye level.
Mm-hmm.
Touch can be appropriate, it may not be. And touch may not be necessarily touching the patient at that moment, but even putting your hand like on the bed or kind of near them, it's just this connection of like I'm here with you,
Mm-hmm.
um, and I'm here to support you. I just want to one more thing on time.
Yeah.
I know that you as a provider don't have a lot of time, and there's others on the team that don't either. But think about if you added up all the time from check-in through every member of the team that they touched, that actually ends up being quite a lot of time, and it creates a whole different experience and sets them on a different trajectory.
Mhm. Yeah, absolutely. Which is why it's so important, as you said, that this be a whole team approach, that everybody really be on
Yes.
board with every time we touch, because then we don't feel as the physician or the nurse doesn't feel as the nurse, that
Yes.
we have to do everything to provide that compassionate
No,
care that they need,
no,
because we'll know that all of the other team members
absolutely.
are doing that as well.
Absolutely.
So
Absolutely. And we encourage debriefing, right? So
mm,
that team then is debriefing so that they're getting the care they need, but I feel like we're all learning. And so we're going to improve every time we interact with the patients and their partner and families, but also how we interact with each other as well.
yeah, absolutely. Well, and I would imagine that doing that is why you found surprisingly, which you weren't expecting, but that team cohesion and morale went up
Yes.
too, because
Yes.
as all of us know who have been in stressful, difficult situations, especially in a patient care setting,
Right.
oftentimes that is kind of a bond forged by fire, for the
Yes.
people providing the care as well. And
Right.
so I think that that's so important. Um, well, we just have a minute left, so and we basically got through the questions. I had written down several, but we'll just use them. We'll do another podcast episode with
Okay.
you or something, and we'll go through those questions. But I want to be sure and um, to ask a couple things to just reiterate for the people watching the webinar. Um, can you tell us again, one, where people can go if they want, because there was a question
Mhm.
about getting a copy of the slide.
Yes.
So if people want
Okay.
access to some of the data, the studies that you
Hmm.
shared, Where can they go to get access? I know you all on your website, but I'll have you tell them where have so many resources. So one, where can they go to find some of this data that you shared? And then two, how specifically can they reach out if they would like to see your
Mhm.
training brought to their
Okay.
hospital system?
Yes. Well, I mean, so certainly you already mentioned our website is a great resource, and so that's reproductiveloss.org, um, or reproductivegrief.org, sorry.
Okay.
And then, and I would just say, I mean, I would love to hear from anybody who is interested. And so it's my first name, Michaelene, at reproductivegrief.org. Feel free to reach out, and we can share some of those templates. Also, if there's any interest, I mentioned the full program. We also do break those out into modules. So, there's a hospital in Texas and they wanted to do the best practice coaching. And so that's what we did with their one of their advanced practice nurses. I mentioned one of our hospitals we work with in Washington State. They wanted to have a license and access to all of our on-demand education, right? And then I described scripts where we did all of that together. Some have also just done the multidisciplinary intensive. So I'd love to explore
Mm-hmm.
the different options and kind of see like what might be a fit within their specific setting.
Amazing, amazing. Well, thank you so much for that. And I would encourage anyone who's watching this who wants to learn more or would like to see more of this kind of care offered at their hospital system to reach out to Michaelene and the Institute. And we'll be sure, I'm sure Miriam can drop those web addresses in the chat. So before we close out, first of all, I just want to thank Dr. Friedenberg so much for joining us tonight. This was such an important and informative webinar, and I know that people have learned a lot, and this will be shareable after the fact, so I would encourage people to share this with colleagues as well. Um, Before we say goodbye for good, I just want to quickly direct you to some other resources. If you want to keep up with AppLog and our educational content like this webinar, we encourage you to get onto our mailing list or join us as a member if you are a medical professional. To do that, you can go to aaplog.org/join. Or if you're interested in the advocacy work that AppLog is doing through our advocacy arm, AppLog Action, I encourage you to join that mailing list by going to aaplogaction.org. You can also follow us on our social media accounts. We are on Instagram at applog_, on Twitter or X at applog, and on Facebook at Pro-Life OBGYN. So we encourage you to follow us for excellent educational content, including more from Dr. Fredenburg. So thank you so much for joining us, and we look forward to seeing you for our next webinar, which should be sometime in the month of July. Thanks so much for joining us.